Yes, sir, myself, sir.
Go ahead, madam. Go ahead.
My
Go ahead.
my
Was
case
very.
is 28 years, primey, 34 weeks of gestation with thoracolumbar kyphoscoliosis posted for elective Lscs.
Mm.
First, I would ask the mother history of any
Mm.
presenting illness, history of
Mm.
breathlessness, the onset and progression, whether it has plateaued at term or it has become severe as gestation is has increased. History
Mm.
of any palpitation and presence of bilateral pedal edema. I would also like to inquire about other histories such as history of syncope, chest pain, or paroxysmal nocturnal dyspnea, headache or blurring of vision, any cough with expectoration or hemoptysis or evening rise in temperature, and any history of bleeding PV. Coming to the history of present pregnancy, I would like to ask about the first trimester history, about the regular antenatal checkup, the ultrasound, regular antenatal checkup, doses of tetanus toxoid and folic acid taken, and history of breathlessness. In second trimester, I would ask about the quickening and the history of hypertension, any hypertension, gestational diabetes mellitus or gestational hypertension. And third trimester, the same history as before. In past history, I would like to ask about the recurrent respiratory tract infection, any neuromuscular disorders or cerebral palsy in the past. If the patient is a known case of uh, uh, any presence of vertebral tumors or trauma to the spine. Family history, history of any sudden death among family members after anesthesia in any surgical procedure. I would also ask history of any previous surgery for the patient, and the anesthesia and post anesthesia events, allergic history and drug history in the past. On general examination, the patient is conscious about the consciousness level, orientation to time, place, and person, build and nourishment, height and weight of the patient, weight gain during pregnancy, any pallor, pedal edema, any presence of elevated jugular venous pulse, icterus, cyanosis and clubbing, and lymphadenopathy, a total head to foot examination. I would also like to do a detailed examination about the spine. In the spine, I would expect a severe kyphosis in the thoracic region and scoliosis in the lumbar region, and with no tenderness. Vitals. I would also, in the spine, I would also look for the presence of spinous process and the interlaminar space. Vitals, heart rate, BP, temperature, and respiratory rate. And respiratory rate, I would see whether the breathing is regular or irregular. If the patient is normal or tachypnic, I would also like to record the room air saturation, SpO2. SpO2, I would like to record in the supine position and in the left lateral position. Airway examination. Mouth opening, thyromental distance, the temporomandibular joint, and Mallampati grading, and also I look for the neck movements. Coming to the investigations, I would like to order, apart from the basic investigations like blood investigations, I would also like to order a pulmonary function test to see whether it is a restrictive pattern or obstructive pattern. I would also order an ABG in room air to see any hypoxia or hypercapnia, respiratory abnormalities present. I would also like to order a echo and ECG. I would expect any signs of pulmonary arterial hypertension and right heart failure. Um, so summary, this is a 28-year-old female has come uh, with 34 weeks of gestation with thoracolumbar kyphoscoliosis, has come for elective Lscs. Um, so pre optimization, I will counsel the patient about the plan of anesthesia before before taking the patient to OT. I would also counsel the patient about breathing exercises. I would give incentive spirometry and ask, then also if any bronchodilators, if any obstructive element is present, obstructive pattern of is present. Then challenges in this case would be pregnancy itself a challenge, and next kyphoscoliosis, since it is associated with cardiorespiratory system, and also abnormal spinal curvature. It will also affect the positioning and descent of the fetus during labor. I would expect a prolonged labor. So first, my plan of anesthesia, I would go with plan A. My plan A would be a neuraxial anesthesia choice because of cardiorespiratory, of anticipated cardiorespiratory problem. I would go for a neuraxial anesthesia. Uh, Pre-operatively, I would identify the surface landmarks and interspaces which is least affected by the deformity. Then, if I'm not able to identify, I will go by ultrasound method using a curved array probe. I'll identify the interspace. Then, mostly by modified paramedian approach, I will try the a single shot spinal anesthesia with 25 gauge Quinky needle, sir. And I'll check for levels of blockade up to the T4 level. If the level has failed before the skin incision, if the level is not achieved before skin incision, or if the level has not achieved before opening the peritoneum, I will convert. My plan B would be general anesthesia with endotracheal intubation, sir.
That
Yes, sir.
okay. So what should have been told at the very beginning, you have come, you have mentioned as a summary at the very just before conclusion of your presentation. Okay. As I have been repeatedly telling, whenever any case scenario is given, always first start with the challenges or the problems that you have at that case. Okay. So here is a patient who is already having a musculoskeletal disorder in the form of thoracolumbar kyphoscoliosis. She has incidentally married, got pregnant, and become a pregnant woman who requires a cesarean section, isn't it? So your history taking should first focus on the kyphoscoliosis, when it was diagnosed, how severe it is. See, when she has a thoracolumbar kyphoscoliosis, why nobody has advised her to go for any treatment? Nowadays we have surgical corrective treatments available for kyphoscoliosis. Is it because of the patient's ignorance, low socioeconomic status, not knowing what to do about it? She just like that grew. It happens in the rural areas. They are not aware that some kind-hearted person marries that lady and she becomes pregnant. All these things can still happen. But you must take a full history of at what age the scoliosis. What is the common type of kyphoscoliosis, which is among the classifications of kyphoscoliosis, which is the common type of
Idiopathic.
adult
Idiopathic.
idiopathic, adult idiopathic kyphoscoliosis. Okay, so that starts occurring in the patient after the age of 10 or 11. As they start growing, it starts becoming more worse. And any evaluation of the cob angle was done or not, that has to be found out. Okay, has it been progressing very badly? Does it cause any gait problem? And was it affecting the growth of the child? How, because the abdominal proportions also, the pelvis gets tilted. So the pregnancy itself could have had problem because of that. Okay. So despite all that, she has now come up to 34 weeks, means that she is quite lucky and she is requiring elective cesarean to deliver that child, because as you rightly said, the problem of allowing a normal vaginal delivery may be more difficult in that. But once there is a thoracolumbar kyphoscoliosis, your concentration must go on the underlying lung development, whether it has been developed normally or whether it has become rudimentary. And if it is rudimentary, what is the risk or danger in that patient? For example, the segment of the thorax which has collapsed, in kyphoscoliosis of thoracolumbar origin, your thoracic cage becomes narrow in one part, the opposite side expands. Okay, so the lung may be not well developed in that part where it is collapsing, and that may lead to pulmonary hypertension, which will
Hypertension.
lead
Yes.
to right heart failure. Okay, so
Yes.
your history should be concentrating on whether patient has, of course, you have said about the syncope history and the breathlessness history and all those things, and it produces more of a restrictive pattern of lung disease rather than obstructive pattern of lung disease because of
Yes.
the mechanical the inability to expand the chest wall. Okay, so that is what is happening in these patients. And uh, there is a good article in again World Federation of Society tutorial of the week about how to judge whether we can go ahead with a regional technique, because technically it is challenging to give a spinal in a patient with thoracolumbar scoliosis. So they have given a guideline where based on the Cobb's angle, they have classified it into mild, moderate and severe degree of Cobb's angle. And in that situation, based on that, you can go ahead for spinal or even epidural has been tried. And whether another history you should ask is, here it is not mentioned, whether any attempt to correct the kyphoscoliosis was done prior to surgery, whether the patient underwent any surgical procedure and any fixation. In that case, this is going to be much more a challenge for giving a regional block rather than you can straight away go for a general anesthesia. And general anesthesia, especially in a thoracolumbar kyphoscoliosis, also may be challenging because it may restrict the airway, the neck
Got it.
movement, the mouth opening, all these things may be quite challenging if it is encroaching on to the lower cervical segments also. So the thorough airway evaluation and preparation for a difficult airway should also be planned in these cases. So it is not that much easy to give GA also in this patient. So here both the challenges of performing a central neuraxial blockade as well as administering general anesthesia because of the difficult airway, both are to be talked about or discussed in these cases. Okay, so I'll just show you again how to go about this.